There's a delay. Here we go. Hello, good afternoon, everyone. We would like to welcome Sheradon Waits, who was going to speak to us about G-tube weaning. And one of the awesome things we know, other than her being a nurse practitioner, is that she is also a heterotaxy parent. So what a blessing to hear from her today. Go ahead.
Awesome. Well, first of all, I'm really excited to talk to you guys today about G-tube weaning because, in my opinion, it's kind of like the newest, latest, and greatest, especially for our cardiac kiddos. Heterotaxy kiddos, of course, included in that umbrella. Just a little bit about myself, if my computer will let me. Uh-oh, hold on. It's not letting me advance my slide. There we go. I am, as she mentioned, a pediatric nurse practitioner in cardiology. I've been in pediatric cardiology for 16 years, 5 as a bedside nurse and 11 as a nurse practitioner. Back in 2019, I was pregnant with our 4th child, a baby girl. And when I was 20 weeks pregnant, we found out that she had heterotaxy with a right-sided stomach, dextrocardia, double outlet right ventricle, transposition of the great arteries, multiple VSDs, pulmonary stenosis. And then when she was born, we found out she did have malrotation of her intestines. So that's kind of like, in a nutshell, her. And then we ultimately ended up with a G-tube when she was about 11 weeks old post BTT shunt surgery. And then she completed a G-tube weaning program here in Dallas in like March, April of 2022. So that's kind of where my experience comes from in this. So a little bit about G-tube weaning programs. I'm sure many of you have heard this concept. It's relatively new. I did not hear about G-tube weaning until that would be summer of 2020 when my daughter was inpatient with her BTT shunt. And obviously I've been in the pediatric cardiology world, and it was kind of one of these things where these kids get NG tubes placed or G tubes placed while they're inpatient, and then we send them home on a feeding regimen, and we're inpatient, so you don't hear what goes on outpatient with them. But G tube weaning, when I was researching it a little bit, there was a big study done in 2018 about weaning program, but I mean, 2018 was only 5 years ago. So relatively speaking, this is new. Obviously, different centers do it different ways, and there are different types of programs. So the program that we did, which I'll get into more, was a outpatient program, meaning we did not stay inpatient anywhere. We had appointments once a week, but we didn't actually go inpatient anywhere. There are, at least in Dallas, where we live, there are programs that are very intensive, like for 4 or 5 weeks, you're there every single day or 5 days a week for 8 hours. So those have been around a little bit longer, but this kind of like do it at home with the supervision of a multidisciplinary team is a little bit of a newer thing that I think, from what I've heard and the numbers that I've seen, is working out pretty well. So multidisciplinary team is involved. You have to have a big team of people, speech therapist, nutrition, cardiologist. Our cardiologist wasn't in charge of the program per se, but she did have to give her okay that our daughter's name is Mabry, by the way, that our daughter Mabry was in a good position, cardiac wise, medically wise, to be able to go through this program. Psychology was also involved, just from like the emotional behavioral aspect of it. Our G-tube weaning program for our cardiac kids here in Dallas is actually led by a nurse practitioner, which I think is amazing for obvious reasons. But she's a nurse practitioner that works in the office with me with our cardiac patients. And she saw a big need for this and had been reading about how other heart centers in the nation were doing this. And she was like, you know what, I think we can do this. Let's start it. Let's try. And Mabry was actually our first patient that did the tube weaning program. And then I think in some situations, in some cases, it might be appropriate to have a GI doctor on board, like the patient, the child's primary GI physician. Mabry didn't necessarily have that because we really didn't have a lot of GI things going on other than the fact that she had had a LADS procedure and she had a G-tube. So when you're talking about who's appropriate to start a G-tube weaning program, you definitely need to have a child who has some oral skills, right? So you can't go from like a complete oral aversion to tube weaning in 5-6 weeks. So a patient, a child who has been working with speech therapy, who will maybe put things in their mouth, but not necessarily getting any type of nutrition per se orally. I know in Mabry's situation, when they did her evaluation, which I'll kind of get to in the next 2 slides, they were concerned that she would not tube wean because she wasn't getting any nutrition from food. She would literally kind of like put small things in her mouth, but that was about it. And she didn't drink any water or fluids by mouth. So obviously hydration was a big concern in the beginning, which I'll also talk about. The patient needs to have a good growth curve. So if you're not in a good spot, medically speaking, and you're not having good weight gain, it's not the time to try G-tube weaning. So when Mabry did her G-tube wean, she was post biventricular repair. She was about 9 months out from her biventricular repair. We were very stable from a cardiac standpoint. Everything was functioning well, and she had been gaining good weight and had a good growth curve, as you'll hear people talk about. This is a picture of our G-tube weaning team that we had. Speech therapy, psychology, nurse practitioner, nutrition. That's myself and Mabry in the middle. That was the very first day that we got evaluated by the team. So the biggest barrier that I see to tube weaning programs like this is that you have a lot of care providers involved. And so getting a team that big to come together and collaborate proves very difficult. I'm sure that a lot of you have had situations where your team has tried to do a care conference or set up a care conference with multidisciplinary team, and it's difficult to get everyone together. Everyone's busy and timing and all of that. So one thing I heard from Mabry's home speech therapist that we had since the beginning, who was truly amazing, was that she had patients who were ready to tube wean, but no one wanted to claim ownership of it. So like the GI doctors would say, oh, well, I want cardiology to own this. And cardiology is like, well, we don't do tube weaning. We need nutrition to figure that out, or speech therapy. So really, I think the biggest barrier to a good tube weaning program is getting a whole team together. I know that Callie, which is the lady that you see on the right with the glasses and the black vest and the gray pants on, she is the nurse practitioner who heads up our program in Dallas. She put a lot of hours and a lot of effort into figuring out how to make this work. The Heart Center speech therapist, who is Brittany, who is in the purple scrub top in the picture, also fabulous. It was kind of like her managers, her teams were like, oh, we don't want to take time away from her inpatient patients. But the Heart Center was saying, but can we give her a little bit of time to work with this tube weaning program? And, Callie, the nurse practitioner, is like, can you give me some allotted time to work with this tube weaning program? And the Heart Center saying, well, is this cost effective for us? So truly getting the team together, and I think sadly, but true, proving that it was worthy of us doing was a big problem, a big barrier in the beginning to starting the program. Another thing that I am huge about is parental advocacy. So we have had patients who come in who are like 3, 4 years old on a tube weaning or on a tube feeding schedule that's like every 3 to 4 hour feeds. And this is not the fault of the parents. This is the fault of their team not looking at this and saying, why is a 3 or 4 year old eating every 3 to 4 hours, right? Like if there's not a medical reason for it. And so I think, unfortunately, a burden put on the parents is that you have to advocate for, can we talk about weaning the G-tube feeds? Can we talk about condensing feeds a little bit? Because obviously condensing feeds is a huge step in making them hungry and making them want to eat and making their stomach have that feeling of hunger and then satisfaction post feeding. So I always tell parents when they leave the hospital, if they're asking me questions about an NG tube or a G tube and like, well, how long are we going to have this? And I just tell them, really advocate in the outpatient setting at your appointments with cardiology, with GI, with your speech therapist. Like, hey, I think my child is ready to condense the feed time a little bit, or I think my child is ready to start tube weaning. What can we do? And obviously not all centers have a tube weaning program yet, which makes me really sad because I think that we do these patients and families a big dissatisfaction, a big, it's hard because eating normally and not eating with a G tube is not normal, right? And the whole reason why we do all of these things is to give our children the most normal childhood that we can. And so I feel like it's something that we definitely need to work on and strive better at. Another barrier, obviously, insurance companies and cost. So when we started the tube weaning with Mabry, obviously this was Callie's team's first patient. And so they were trying to figure out all the hoops they were going to have to jump through. And one of the problems that they found was that Brittany, the speech therapist that I talked about with the tube weaning program, who's the inpatient speech therapist, they were afraid that she wouldn't be able to bill for her speech therapy services when she saw Mabry once a week because Mabry had home speech therapy 3 times a week. And so they said that typically insurance companies won't let you bill for 2 speech therapists, which I mean, kind of makes sense. Fortunately, the insurance company, they appealed to them and said, hey, this is why we need 2 speech therapists. And in the end, it will be cost worthy to you because if she tube weans, you won't have to pay for G tube supplies, feeding bags, pump, formula, all of that. And it worked. But and I think that the longer your team's been around, the better they get at that and like knowing what to say or what hoops to jump through with the insurance companies. But obviously definitely can be a barrier. And then the time commitment. When we did the tube weaning program, and I'll talk a little bit more about exactly what it looked like, we had once a week appointments. We had a daily commitment of weighing her and charting that. And then we also had to keep track of her, everything she ate in a day, even if it was like 3 goldfish. We had to write it down and document it in her little iPad program. So it is a big time commitment. And I understand that a lot of families are really busy. Mabry is our 4th child. I work full-time as a nurse practitioner. My husband works full-time as a teacher. And I'm not going to say that it was easy. But because I am a nurse practitioner who works 12-hour shifts, I did have 2 days off a week that allowed us to do that weekly appointment. But I understand how for a lot of families that would prove very challenging. So what does tube weaning actually look like? Like I kind of already talked about, it varies at different institutions how they do it. But from my understanding, kind of the plan that I'm going to tell you that we did is kind of standard, I guess. But the first step would be the evaluation, which I kind of alluded to in that picture. The first day that we met with the whole team, we came into the cardiology clinic. That whole team of people met with us. They watched Mabry with food. The speech therapist watched her closely with food. They gave her her typical sippy cup that we had been trying to get her to use. And they watched her with that. She did like making sounds with her and just watching to see if she put things in her mouth, different things like that. Obviously, psychology asked us a bunch of questions about like, well, how does she do with this? Or how does she respond to this? And when did she get the G tube and all those types of things. And then nutrition was there to say, kind of, hey, this is like, she helped come up with the plan of like, this is the bare minimum of what she needs to do, or this is the amount of weight loss that we're okay with before we stop the tube weaning program. Because I will say that all of these programs, when you start them, they anticipate a certain amount of weight loss. And then if you drop below that, that's when they get concerned and say like, okay, maybe we need to like back off on the weaning a little bit. So the tube weaning program and implementation. So we met with our team the very first day for the evaluation. And then about a week or two later, Callie, the nurse practitioner, gave me the plan. And I have to say, when I brought this plan home and showed it to my husband, he looked at me and he said, "How much do you trust Callie?" Because it was such a huge drop in feeds. So essentially what it was, more or less, if I'm remembering all correctly, the first day that we tube weaned her, we cut her formula feeds by like 25%. So we essentially took off a quarter of all her feeds. And so we just took that off the volume of each feed amount that she was getting a day. She had been condensed to like, I want to say 5 feeds a day, maybe like 3 during the day and 2 at night or something like that. So she had been condensed some. It's not like she was getting every 3-hour feed still like a newborn, but that's what we did. 25% cut the first day. And then, and obviously offering her food at meal times, snack times, or any time really that she showed interest. And then having that sippy cup for her and offering her water whenever she wanted it. Like basically we just lived with the sippy cup with us. And her speech therapist here at home had started working with her with a straw quite a bit. And I should say she was 4 months shy of 2 years old, I think, when we started this. So just to give you like an age time frame. So that was the first wean. And then it was only like 5 or 6 days later that we cut the feeds by 40%. So we went in and cut the amount of formula she was getting in each feed by 40% total of what we had started at. And then 5 or 6 days later, we dropped it by 60%, I believe, 55 or 60%, and then like 80%, and then fully off. So from the time that we started the tube wean, the actual wean, the first day we did the wean and formula, to the time I would call her completely tube weaned was only about 5 or 6 weeks, which still blows my mind. And obviously every patient is different and not every kiddo does it that quickly, or some kiddos may do it faster. But essentially the idea behind it is you want to push them to be hungry and start to correlate, oh, I ate some goldfish and now I don't feel as hungry. And then same with the drinking liquids. You want to push them to be thirsty so that they will want to drink water and keep themselves hydrated instead of us doing it for them. Obviously, there's a lot of data gathering that we did during this time so that they could keep her safe. So we had an iPad that was given to us by our hospital program, and it had a program in it. I don't remember the name of it now, but we would go in every day and record her weight. So we had a home scale that they had given us, was lent to us, and we had to weigh her every day at night at the same time. And then we had to record every single day how many ounces of fluid she took and how much she ate. And like I said before, it would literally sometimes be like 3 goldfish, half a string cheese, 2 bites of yogurt. I mean, it was pretty intensive to try to keep up with that and making it equally challenging. She was in a daycare at that time. They did her tube wean or her G tube feeds. We got really lucky, and they were willing to do that for us. But we had to ask them like, hey, anytime you see her eat something, please write it down for us so we can record it at the end of the day. And then we also had to record in that app her number of wet diapers and number of stools that day, so they could keep an idea of like how well hydrated she was. We did have for follow-ups, we did have weekly meetings with the team. Sometimes they were virtually, most of the time they were in person, but you have to remember we're still kind of like in the COVID phase, not as bad, but we were still doing some virtual meetings just so we didn't have to go in every single week. And then they watched the app, they watched all our numbers on the app. And if there were like 2 days of weight loss when we didn't think there should be, Callie would text me and say, hey, what's going on? Or, how is she doing? Does she seem well hydrated? Is she still having the same number of wet diapers? That type of thing. And then we had a couple of appointments even after she wasn't getting any tube feeds. Obviously, we had a few more follow-ups before we were officially like discharged from the program. And then that was just basically them saying like, she's tube weaned. We don't think she needs us anymore. Around the same time, obviously her home speech therapist was like, she doesn't need me anymore. She's eating and drinking everything by mouth. So we got discharged from that as well. For parents wondering, I did keep the G tube in, and my full intention was keeping it in for a year because of, well, the next slide, not this one, but because of regression. Like if she were to get sick with a really bad cold and wasn't eating and drinking as well, we kind of would like have that as a backup. But she self-removed the G tube in the middle of the night about 3 months later. So that didn't happen. Potential risk involved with G tube weaning. Obviously, we kind of talked about this, but like the risk of dehydration if they're not drinking enough fluid, constipation because they're not getting as much fluid or food. I will say our nurse practitioner did prescribe lactulose just preemptively, like at PRN, and was like, you can give it to her twice a day if she needs it, if she's getting constipated, which we didn't have. I gave it to her a few times, but we didn't have a ton of issues with that. Malnutrition, weight loss. That's why, we did the weights every single day. And obviously we're watching her very closely. And then of course there's stress and anxiety involved. I'm a pediatric nurse practitioner. I work with cardiac kids all the time. And this made me extremely nervous, just because it is such a drastic cut in calories and formula. But the concept behind it is if you wean them super slowly, you don't give them a chance to be like, yeah, I'm hungry right now, I want to eat, or I'm thirsty, I want to drink. Like it's like a slow wean doesn't really do much for them. You have to cut it a little bit more drastically if you want to see results. Now, I'm not saying always. I'm sure there are kiddos who have weaned successfully with really slow weans, but this is kind of like what the numbers have shown. And I will say our program, I don't know the exact numbers, but to date, they've weaned at least 10 kids. And last I heard, we had 100% success rate with tube weaning. Now, I will preface that by saying we obviously can cherry pick the patients that we choose for the tube weaning. We can pick the patients that the parents are like, yeah, they put things in their mouth, or, they've been working with speech therapy since birth and they don't have like a true oral aversion where they gag anytime anything's put in their mouth. And you want them to be at a stable cardiac standpoint too, or any other systems that have been an issue for them, because you don't want them to be like tenuous medically, and you're trying to wean them off of their nutrition that they need. So stress, anxiety from the parent standpoint or caregiver or the patient, the kiddo. Obviously, Mabry was less than 2, so she didn't really know what was going on. And she's a super happy-go-lucky kid all the time, so it didn't really outwardly to us appear that it caused her any issues. This is Mabry working with her home speech therapist that we had for like 2 years. Loved her so much. But obviously there might be bumps in the roads, regressions, like I talked about, illness, colds that have like cause a lot of mucus or vomiting that could cause issues while they're tube weaning or after they've tube weaned. Emotions, especially if you have like an older child doing this. And then like we already talked about, stress and anxiety. What tube weaning did for our family. I truly simply cannot put into words what having her weaned off of the G tube meant for us. Last summer, for the first time, we took a vacation, a family vacation as a family of 4. And besides COVID, of course, the main reason why we hadn't taken one is because she was G tube fed. And it's not that you can't go places with G tubes. Obviously, we all know that that is doable. And she had the little backpack that was specially outfitted to carry the pump and the feeding bag and all that. But we just felt a lot more comfortable doing it after she was tube weaned. And so we didn't have to pack up all the formula and the pump and the supplies. And what are we going to do if she pulls it out in the middle of the night? Is there a pediatric hospital nearby? And we have to make sure we have the extra button with us and all of those things. And then just like normal everyday stuff, birthday parties. She goes to birthday parties and gets to eat the cake or the cupcakes, family dinners. You know, she is with us for all of it now. And I don't feel like she's like being left out of any part of it. So it did obviously wonders for us. That's all I have. I'm just opening it up for questions. If anyone has any questions, there's obviously some pictures of Mabry doing what she does best now, eating. She's making up for lost time these days and loves to eat. But if you guys have any questions, I'm happy to try to answer them.
All right. Is there anyone here in the room or on the chat? Does anyone have anything? So our kiddo, I'll just start us off. Our kiddo never ended up having a tube. He was able to be orally fed, but a lot of what you had said about like the measuring and the weighing and the intake, we did a lot of that when he was interstage.
Yeah.
Yep. So I'm like, oh, yep, that tracks. Yep. Definitely.
We did that too. And it was the same program that we used interstage that we used for the same app.
Yeah. So then when you're making, I know you spoke to how it's a bit nerve-wracking to make that big cut. How did they decide what she would be able to tolerate versus not? Like how are those kind of decisions made? Because I know not everyone has a team, an amazing team like that behind them. So if our families are going to their local people and saying, hey, I want to push for this, what are some of the things that they should be watching out for in terms of considerations there?
I mean, I think the biggest thing that our dietitian went off of was weight loss. What percentage of weight loss were we okay with? Because there's going to be some weight loss, right? Because they're going from getting 100% of their caloric needs to who knows, 10, 15% of their caloric needs. And then obviously with the dietitian being able to look at what we've been recording every day, she could kind of do like a calorie count and be like, okay, she's meeting this percentage or this percentage. And I don't know exactly what the percentage of, I don't even think they used caloric need percentage per se. It was all about weight. Like what percentage of weight loss are we okay with?
Okay. Are you able to see Jennifer's question on the screen there? She is in Dallas and she wants to come to you.
So, Callie Linfest, who I don't know if Jennifer knows or not, Callie Linfest is the nurse practitioner, and she's also the nurse practitioner that does our interstage program. We call it the Safe at Home program in Dallas. She's the nurse practitioner who does that too. So she is the person to contact if
Can you send me her contact and then I'll pass it on?
Yes. Okay. Yes. Does that work? Yes.
Perfect.
Yeah.
This is Monica again. I'm going to ask the question. I have my daughter has had some sort of tube, NG to start, and then she got her G tube at 8 weeks old. And she's kind of one of those kids that is probably going to rule the world one day. And she knows exactly why she has the tube and why she still has the tube. And so we've actually, through various approaches, have weaned her from the tube a couple times in her life, and she went over a year without needing her tube, and then was then again diagnosed failure to thrive because she's stubborn, not because she actually was not capable of eating. And so there's a lot of the psychological aspect of it. But what my question to you from having that experience is there a plan in place with your program for those who make a regression for whatever reason, where they have a surgery, get sick, or just are very strong-willed like mine? And do they just repeat the program, or is there like a follow-up protocol, so to speak? And
yes.
Yes. Okay.
Yeah. Well, first of all, bless you for having one of those. Mine can be like that at times because she's a redhead. I have not heard to date any of our patients having that. I will say that we won't wean them if we know they have a big surgery coming up, or that would be, if we know they have, just because of the regression risk. And we encourage families to keep the G tube in for a while afterwards for obvious reasons, like you just said. I know that some parents, there has been an issue with some parents pushing really hard to take the G tube out right away. And we're like, no, we don't want to do that. But to date, I haven't heard of anyone regressing like that, like where they've been weaned for a year and then all of a sudden they're. I do know that the psychologist that was on the team talked a lot about, like, if they're older, when you tube wean them, you really have to worry about like behavioral things and them knowing what the tube is for and all of that. So I don't have a great answer for you on that one, but
I don't think anyone has a great answer for Lauren.
Yeah, that's tough.
Lauren has her own answers. Yes. Do we have any other questions from anyone in the chat? Or anyway, we are so grateful. This is great information. We keep getting so much to think about with everything. So thank you so much.
I really am a huge advocate for this, and I really hope that it starts to help families get tube weaned. I will say that, I talked about advocating, but even just the other day, I was in surgical rounds and we were talking about discharging a patient with feeds like every 3 hours over an hour, hour and a half. And the surgeon was like, it's okay, just get him out of the hospital and they'll wean it outpatient. And I looked at him and I was like, not necessarily. It doesn't always happen that way. Like, the parents don't know to ask, or they're obviously excited to get out of the hospital too. They're like, yeah, just get me out of here, I don't care. But you can't live like that forever. You have to at some point at least condense the feeds, if anything. So I think it speaks volumes that even the cardiothoracic surgeons who do heart surgery don't really know what goes on outpatient.
Yep, that sounds about right. Yeah. Getting teams to coordinate inpatient, outpatient, it's hard. So thank you so much for sharing with us. Are you okay if we let people reach out to you if they have questions? Is that okay? Okay.
Yeah, you can give them my email address.
To check before I send them to you.
Say hi. Mabry would like to say hi.
Hi, Mabry.
Can you say hi? Say hi. Hi. Are you being shy?
We
just
saw
finished
pictures
talking about
you.
But thank you guys so much for this opportunity, and I super duper appreciate it and hope that it helps even just one person out.
Absolutely. Thank you so much.
Thank you. Have a great time, guys.
Bye-bye.